This is a case of Coblation Tonsillectomy of the right side. We are using EVAC 70 by Smith and Nephew plasma wand. We are using the wand at a setting of 7 for ablation and 3 for coagulation. We are holding the right tonsil with the help of an Ellis forceps, and we are incising the mucosa with the help of the wand. We are using the ablation mode for the incision. We are incising just lateral to the anterior pillar. We can also go a little lateral to the pillar to find out the correct plane of the dissection. It is very important to find the avascular plane for our dissection, as if we do not find the correct plane, we will leave the tonsillar tissue behind and it will lead to the recurrence. We are at the upper pole and the tissue is more firmly adherent at the upper pole and the lower pole. We have to divide the connective tissue and not the muscle fibers. We have to prevent opening up of the fascia, as it will opening up of the fascia will lead to the exposure of the floor muscles, tonsillar bed muscles, and it will lead to a complication of post-operative pain. The pain in the tonsillectomy is due to the exposure of the muscle fibers or the myositis. So if we prevent the opening up of the fascia or the exposure of the muscles, it will be a purely painless surgery. As you can see, there is very minimal bleeding at the dissection because we are in the correct plane. We have to divide at the junction of the tonsillar tissue and the fibrous tissue. This will help us to be in the correct plane. As we progress our dissection, we have to hold the tonsil or pull the tonsil medially, and we have to change our grip according to the place we are dissecting. We can also push the tonsillar bed or the tissue laterally so that it helps us in dissecting in the correct plane. We can use the coagulation mode if we see any bleeding. So far, we have encountered a very minimal bleeding. We can clearly see the differentiation between the tonsillar tissue and the fibrous tissue, and I am dividing at the junction of the tonsillar and the fibrous tissue. We can see the cotyledons of the tonsillar tissue coming in our view. The minor oozing or the bleeding can be controlled with the help of coagulation. We have to use the concept of traction and the counter traction. Generally, the infected tonsils are the one which bleed and they are very vascular. We can use the coagulation mode wherever we feel there is a little bit of bleeding or the oozing. The oozing which we are seeing are the capillary bleeding or the venous bleeding, not the arterial bleed. And in the tonsillectomy procedure, this is considered a very minimal bleeding. Now we have to keep separating the tissue from the bed. So you can see I am doing a prophylactic coagulation in the area of the tonsillar artery. This area is approximately where the tonsillar artery enters the tonsillar tissue. The tonsillar artery is having a large caliber in the lateral aspect of the tissue. As the artery goes medially, the caliber of the artery decreases. So the chances of the bleeding is less when we first coagulate and dissect at the medial most part. The tissue at the lower pole is more adherent to the tonsillar bed and it is little difficult to separate the tissue from the bed. And in a case of chronic tonsillitis where there is repeated infection, the tonsils are fibrosed and it is difficult to find the correct plane of dissection. But once you find the correct plane of dissection, the tonsillectomy procedure is a very easy procedure and it can be done within few minutes. The little bit of the oozing can be stopped using the coagulation. And as you can see, the tissue is a little firmly adherent and I have to do a little more of the ablation at the lower end. The movement of the wand and the speed of the wand should be optimal. If the movement or the speed of the wand is too fast, the ablation mode will not coagulate the little bit of the small vessels which are present, and if the movement of the wand is too slow, it will cause the charring of the tissue or the burning of the tissue. The speed at which you move the wand should be optimal. You can see the tonsillectomy on the right side is complete and there was minimal bleeding, and almost in the 60-70% of the tonsillar bed the fascia is not exposed. As this was a extra capsular tonsillectomy, the opening up of the fascia was inadvertent, but we can minimize this in the procedure. Little bit of the tonsillar muscle fiber, bed muscle fiber can be exposed, which can lead to little bit amount of pain in the post-operative period, which can be managed with the help of analgesics. So our tonsillectomy procedure is complete on the right side. I'm just finishing up this side by doing a little bit of the coagulation so that there is no post-operative bleeding. So this is for this video. Thank you for watching.